Well, thank you very much and welcome everyone. Welcome to Advancements in Atopic Dermatitis. What does this mean for your practice? Thank you for joining us this evening, and due to cancellation of meetings and events necessarily imposed by our society's response to the coronavirus epidemic, our planned in-person seminar is being conducted tonight exclusively as an online seminar. Thank you for attending virtually. We have worked hard to ensure that practitioners in the field will gain the benefit of the information we are about to present as you earn educational credit for your participation. To those who are not in the dermatology field or in pediatric practices, welcome, and we hope you too gain valuable information for this event. My name is David Guyden, and I am Executive Director of the Asthma and Allergy Foundation of America, New England chapter. Before the introductions, a few notes for those of you who are joining us remotely via our Zoom broadcast. All attendees are off camera and automatically placed on mute. During the session, you will have several opportunities to respond to a poll. Please participate. Also, feel free to use the Q&A feature if you would like to ask a question. We will attempt to field as many questions as we can in the 1-hour time frame that we have allotted to this event. The program this evening will be recorded and it will be available for future viewing on the AAFA New England website at asthmaandallergies.org. The Speaker Series event is facilitated in collaboration with the France Foundation, with educational grant support from Sanofi, Genzyme, and Regeneron Pharmaceuticals. Thank you very much. The France Foundation offers timely, relevant, and engaging continuing education that helps healthcare providers deliver the best medical care. The Asthma and Allergy Foundation of America, New England chapter, is dedicated to improving the quality of life for those living with or caring for people with the chronic conditions of asthma and/or allergies. Our upcoming spring and fall speaker series events are made possible by a generous grant from GlaxoSmithKline Pharmaceuticals, GSK. Please stay tuned for more high-quality, informative events. At the end of tonight's presentation, Megan McDonald of the France Foundation will inform our medical professionals how to secure your educational credit for attending this evening. She will close the presentation with thanks from us all for the important work that you do every day. Thank you very much. Before we begin the presentation, one disclaimer: any mention or reference to a company, institution, or organization or its available products or services should not be construed as an endorsement or recommendation by AFA New England. Information presented should not be used as a substitute for responsible professional care to diagnose and treat specific symptoms and illnesses. AFA New England will not be held responsible for any actions taken by attendees or viewers as a result of this talk. We are fortunate to have tonight as our guest speaker, Maryanne Senna, MD. Dr. Senna is a board-certified dermatologist at Massachusetts General Hospital and assistant professor of dermatology at Harvard Medical School. Dr. Senna founded and co-directs the MGH Hair Loss Clinic and serves as principal investigator of the Hair Academic Innovative Research Unit, a clinical trials research unit dedicated to hair loss disorders. She has held a number of pharmaceutical, device, and foundation appointments and is working on bringing novel clinical innovations at MGH. Widely published and recognized for her clinical expertise, teaching, and research, Dr. Senna is frequently invited to speak and give lectures nationally and abroad. We're happy to have her here tonight. Beyond adult and pediatric general dermatology and her extensive expertise in hair loss, Dr. Senna's clinical interests include cutaneous reactions to chemotherapeutic agents, psoriasis, eczema, acne, and nail disorders. Dr. Senna is an esteemed member of several professional societies and committees and is on the board of directors of the Cicatricial Alopecia Research Foundation. I'm pleased to turn the program over to Dr. Maryanne Senna. Please welcome Dr. Senna.
Thank you so much, David. That was such a nice introduction. I just wanted to go over a few housekeeping tools. The first thing is if anyone is having any technical difficulties, because the chat feature on the Zoom tonight is disabled, you will need to let the moderator know that you're having technical difficulties, also using the Q&A function, which can be found in the margin of the Zoom conference. This is the same Q&A function, as David mentioned, that you will use to submit any questions that you have that might come up during the talk, and these will be answered at the end of the talk. As David mentioned, this activity is supported by an educational grant from Sanofi Genzyme and Regeneron Pharmaceuticals. And one caveat for you all, because this was supposed to be in person, I did not think I'd be doing it from my home office. I do have 2 young children. It has not been a problem in the past, but I just put it out there in case something unexpected happens. Basically, these are the 2 doctors, Anna Fishbane and Lindsay Stroud, who are the steering committee for this talk. And all of the CME credit information, disclosures, conflicts of interest will be emailed to people who registered for this and available for download after the talk so that you'll have the opportunity to review them. So at this time, I'm going to go ahead and get into the crux of the talk, which is why we're all here. So feel free to minimize my face because the slides do have a lot of good information on them, and I don't want the video to be blocking anything. So I'll go ahead and do that now myself. So the learning objectives are as listed here: to provide accurate and timely diagnosis of atopic dermatitis for patients of various ages, to choose appropriate atopic dermatitis or AD therapy on the basis of mechanism and key clinical trial data, which we will review, and then to address comorbidities when planning for AD care. The differential diagnosis of atopic dermatitis really does come down to a clinical art where a lot of different pieces come in to the picture so that you can make sure that you're providing the right diagnosis and treatment options for any given patient. And so many of us who see these patients all the time understand that atopic dermatitis, also referred to sometimes as eczema, is a chronic, itchy or pruritic systemic inflammatory disease where there are periods of acute disease flares. And up to 20% of children are affected by this and up to 10% of adults worldwide. And the age of onset varies, with 50% of cases beginning in the first year of life, but 25% having an adult onset. And we'll talk about that in a minute. The prevalence for this is increasing, and it tends to occur in families who have other atopic diseases. So with this age of onset slide, what I'd like you to take away here are 2 big points. The first is that the most severe atopic dermatitis tends to occur most commonly in patients who have very early onset and develop atopic dermatitis in infancy and then have it persist into adulthood. So those who develop it very early on as infants and then have it persist into adulthood. The other group that can have very severe atopic dermatitis are for the patients who have very late onset. So these are patients 60 years old or older, and the closer I get to 60, the more I don't like that it's termed elderly. But the other takeaway point is that in patients where this develops either during the toddler years or certainly in the 20s for the first time, when that's the onset, the severity tends to be milder. Not that you can't see severe patients in those categories as well, but overall as a group, they tend to have milder disease. So we know that various things contribute to the development of atopic dermatitis. There's dysfunction of the typically protective stratum corneum, allergen sensitization of the skin, increased bacterial skin colonization, particularly with Staphylococcus, and immune dysregulation that leads to both acute and chronic inflammation. So the role of filaggrin in atopic dermatitis has been well described. This protein is localized to the epidermis and is crucial in forming the protective protein-lipid matrix in developing skin cells. Filaggrin also forms natural moisturizing factors, shown here as NMF, which are crucial to maintaining skin hydration and a low pH. Filaggrin mutations and associated defects in function have been implicated in atopic dermatitis pathogenesis. So let's review a common case that we see in clinic, and we'll be doing this throughout the talk. Now, what I want you to note here, in this case of John J., he's a 47-year-old UPS driver. He has a BMI of 27 kilograms per meter squared, and he presents with a pruritic red rash located primarily on his arms, hands, neck, and back. He says the itching is nonstop and wakes him up at night, and he complains of sleep loss and anxiety, and he's missed work due to fatigue. Now, what I want you to note here is the distribution. We see what looks to be this red scaly rash that's obviously been scratched out. We see evidence of that with the hemorrhagic crusting on the dorsal hands, on the extensor arms, but also on the flexural areas here shown by the antecubital fossa. So if we continue with this patient, he reports past similar episodes that started at the age of 28, but thinks this is the worst one so far. Has no memory of eczema or other skin disease in childhood, but his other health history is notable for childhood food allergies to milk and wheat that ended up going away, and hypertension that's being treated with lisinopril that was diagnosed 2 years ago. So we'll have a question here, and what's going to happen is the opportunity to submit an answer anonymously is going to come up on your screen. So at this point, with the information you know about John J., what is your diagnosis? Is it atopic dermatitis, contact dermatitis, psoriasis, or might it be too soon to say? So it will give you all a minute to select your choice before moving on. So what we see here is that 47% of you thought atopic dermatitis, which makes sense given the topic of the talk here. 11% psoriasis, 42% too soon to say. So for those of you who said too soon to say, you're absolutely right. And we'll talk about why that is in just a minute. So in this case, the answer is too soon to say, because the first thing to recognize is that this is a clinical diagnosis that's made based on historical features, distribution, morphology of the skin lesions, and associated clinical signs. And we know that the first thing to recognize is that there are clinical diagnostic criteria that can help aid in diagnosing patients, particularly those like John J., who is a little less typical because he's older onset, the distribution's a little bit different, affecting both the extensor and flexural areas. And we'll discuss each of the criteria here in some of the common differential diagnoses to think through just next. So before doing that, we have another question, and in this case, it's referring to the American Academy of Dermatology criteria for the diagnosis of atopic dermatitis. And it asks, which of the following is considered an essential feature in making the diagnosis? So the options are personal or family history, A, B, early age of onset, C, chronic or relapsing history, D, xerosis, and E, I'm not sure. So in this case, the answer is a chronic or relapsing history. I don't know if people had the opportunity to vote. It didn't come up for me, but it's chronic or relapsing history. And we'll discuss other essential diagnostic criteria for the AAD in a bit. So the Hanifin-Rajka criteria for atopic dermatitis has major criteria and minor criteria. This is largely used in clinical trials, and you need 3 out of these 4 major criteria in order to meet diagnosis. So the first is pruritus or itching. The second is typical morphology and distribution, so flexural lichenification in adults and facial and extensor involvement in infancy. A chronic or chronically relapsing dermatitis. or a personal or family history of atopic disease, meaning atopic dermatitis, asthma, allergic rhinitis. For the minor criteria, you need 3 of any of these 23 criteria, in addition to the 3 out of 4 major criteria to meet a diagnosis. Of these 23, probably the most common that we see in practice in dermatology are xerosis or dryness of the skin, tendency for hand-foot dermatitis, particularly in the age group of John Jay, pityriasis alba, which we'll see in a moment, which is the hypopigmentation on the face and other areas of the skin. And of course, it's influenced by environmental or seasonal factors. So patients will say that they'll flare during the dry winter months, or sometimes conversely, other patients will flare when they might be more prone to seasonal allergies in the spring and other times a year. So the UK diagnostic criteria for atopic dermatitis, this is mostly used in population-based studies, and it states that patients who, to carry a diagnosis, must have an itchy skin condition or parental report of infant scratching or rubbing in the past 12 months, plus 3 or more of the following: an onset before age 2 years, so it's not used for children less than 4 years old, a history of flexural involvement, history of generally dry skin, personal history of other atopic disease, or history of atopic disease in a first-degree relative if the child is less than 4 years old, and visible flexural dermatitis. Now, the AAD criteria, which is what the question regarding John Jay was about, this is most commonly used for clinical diagnoses. And what the AAD criteria suggests is that there should be 4 essential features that any patient meeting an atopic dermatitis diagnosis should have. And those include pruritus, eczema, acute, subacute, or chronic, a typical morphology and age-specific patterns, so facial, neck, or extensor involvement in infants and children, current or previous flexural lesions in any age group, sparing of the groin and axillary regions, and then finally, chronic or relapsing history. These criteria also point out exclusionary criteria or conditions that would argue against a diagnosis of AAD. And while it lists important features and associated features that can be seen and support a diagnosis of atopic dermatitis, these important features and associated features are not required to make the diagnosis. So when we think about the differential diagnosis, we'll first, sort of look at those checklists and sort of think about our patients and whether or not they seem to meet criteria, particularly with the AAD one if it's in a clinical setting. But then depending on the age of the patient, we're also going to make sure that we're running through our differential. So as we know, atopic dermatitis spares the intertriginous areas of the body, including the inframammary area, the groin, and the axilli. This is in contrast to conditions like scabies, seborrheic dermatitis, tinea, which favor these warmer, moister sort of skin fold areas. Nutritional deficiencies like zinc and also immune deficiency diseases are much less common causes of eczematous reactions in patients in this age group, but they should be suspected if other symptoms or signs are present, such as GI upset or frequent infections or failure to thrive or other things, or if the eczema is particularly recalcitrant despite all best efforts of treatment. Of course, contact dermatitis is one of the trickier differential diagnoses and one of the more common things that we see. But elimination of common potential allergens such as blue diaper dyes, methyl isochlorothiazolinone or MCIMI, which is a ubiquitous preservative, particularly in wipes and other baby products, as well as fragrance, can help to differentiate between allergic contact dermatitis in this age group and eczema. Similarly, allergic contact dermatitis is one of the most common atopic dermatitis mimickers in adults. So careful elimination of common allergens from personal care products is certainly warranted. It should also be suspected in very localized, particularly unilateral eczematous eruptions of the skin. There are others on here that are similar to what we saw with the infant group, namely psoriasis, scabies. You also have to think about any new drugs that might have been started that might lead to a drug eruption. Usually those two are very, very diffuse. And so that distribution can help hint that that might be going on. But an important potential mimicry here to keep in mind is CTCL, or cutaneous T-cell lymphoma, also known as mycosis fungoides. Certainly, again, this is a much more rare potential mimicker than some of the others up here, particularly allergic contact dermatitis for sure. But what some clues that this might be the correct diagnosis is that the lesions will appear to be more red to violaceous in color, and oftentimes will affect what we call a bathing trunk distribution, where the buttocks, posterior thighs, anterior thighs, and sort of lower back are preferentially involved. So again, just to review the typical atopic dermatitis presentations, we'll see in the infant, we see that it largely affects the face, but it can also affect the trunk, and extensor limbs. There can be redness, oozing, crusting, and there can be evidence of superficial bacterial infection as well if there's honey, that yellow honey crust on top of these lesions. In children, the flexural areas of the limbs, and less so the face, tend to be affected. And these appear usually drier, thickened, or lichenified. And because these children can actively scratch, you'll see evidence of excoriations. In adolescents and adults, preferentially the hands and neck are most affected, and also you can see evidence of excoriations and eczematous dermatitis in the flexural areas of the limbs. So some common features that we see, just to review all the way to the left, is an example of lichenification with that thickening of the skin. In the middle, we see that hemorrhagic crust, evidence of excoriations that so frequently occur in these patients. And then finally, hyperlinearity, like we see on the right here with these exaggerated skin lines that can result from the inflammation. Some other common findings in patients with atopic dermatitis, as many of us know, are these spiny follicular rough bumps in the upper outer arms or the anterior thighs, known as keratosis pilaris or KP. As I mentioned before, pityriasis alba, which we see here in the middle, these hypopigmented areas that are largely a post-inflammatory phenomenon. And these can be most easily seen in patients with darker skin tones and may sometimes become more pronounced in summer months when or after a vacation when children might be exposed to more UV light. And finally, ichthyosis vulgaris. So this is the fish-like scaling due to very dry skin that can sometimes be seen in patients. So adult onset atopic dermatitis can be really tricky. And that's because the lesion appearance can vary and appear papular, follicular, lichenoid. And most importantly, the distribution can really vary with lower rates of flexural involvement and a greater predilection for hands, head, and neck, as we discussed. In these cases, it's particularly important to keep a high index of suspicion for other possible causes and keep your differential diagnosis open, particularly initially. And this is why the answer to the John Jay diagnosis question was too soon to tell. So in someone like John Jay, it would probably be prudent to rule out the possibility of an allergic contact dermatitis, late onset, and with the exception of the flexural involvement, some of the other areas affected can be seen in allergic contact dermatitis. But he had patch testing and there were no positive or relevant findings found. In addition, he had blood work, including a complete blood count, complete metabolic panel, total serum IgE and ANA, which were all normal. And so in this case, we can say, okay, well, let's look how he does looking at our diagnostic criteria. Well, if we look at the UK diagnostic criteria, he absolutely meets having an itchy skin condition, and he has 3 or more of the other criteria, namely history of flexural involvement, personal history of other atopic disease. You'll recall he had a childhood history of food allergies, and he has on exam visible flexural dermatitis. And when we look at the AAD criteria, which is most often used in these patients in clinic, he has all of the essential features, namely the itch, the appearance of eczema, and a typical morphology, meaning current or previous flexural lesions in any age group. He also reports a chronic or relapsing history. He has some important and associated features that support it and no exclusionary conditions that would argue against the diagnosis. So with proper workup and use of diagnostic criteria, we can now confidently provide him an atopic dermatitis diagnosis. So let's turn our attention now to atopic dermatitis comorbidities and start off with a question. In the atopic march, which allergic comorbidity typically appears first after atopic dermatitis? So again, I can't tell if the if the answer options are coming up, but they are A, asthma, B, food allergies, C, skin allergies, D, allergic rhinitis, or E, I'm not sure. There we go, I can see it now. So I'll give you all a minute to answer that. Answers, oh, there we go. Wonderful. So 32% of you answered asthma, 32% food allergies, and then skin allergies, allergic rhinitis, and I'm not sure. So great. So yes, in this case, the answer is asthma. And as we know, the atopic march describes how patients who have an allergic disease are more likely to develop another or multiple allergic diseases in their lifetime. The progression commonly starts with eczema in infancy and can develop into food allergy, asthma, or hay fever in childhood. And there's also more recent evidence that eosinophilic esophagitis, or EOE, can be a late but probable part of the disease progression. And that's from research done in 2018 that looked at the rate of EOE and its association to other allergic diseases in a cohort of over 130,000 children. And they found that children with eczema, food allergy, or asthma all had a greater risk of developing EOE than children without the conditions. In addition, they found that the cumulative risk of EOE went up with each subsequent atopic or allergic disease, indicating that EOE falls into the pattern of atopic march. However, and that they also commented that EOE tends to be diagnosed later in the progression, so like later in childhood. I think it was around 6 to 10 years of age. So if we look at the full spectrum of AD comorbidities, we see that various things contribute, namely the propensity for infections, the increased anxiety, depression, sleep disturbance that comes along with the diagnosis, other atopic conditions, skin pain, and even cardiovascular and metabolic issues. So the relationship between atopic dermatitis and heart disease seems to be mostly seen in patients with moderate to severe atopic dermatitis. And this slide demonstrates the direct effects of moderate to severe atopic dermatitis on anxiety, depression, and diabetes, the direct and indirect influences on obesity, and the indirect effects on hypertension and heart disease. So this data is from a systematic review and meta-analysis of 19 studies that looked at associations between atopic eczema and specific cardiovascular outcomes, suggesting that there is no significant direct effect of atopic dermatitis on heart disease. Specifically, the effects of atopic eczema reported in cross-sectional studies showed no evidence for pooled associations with angina, myocardial infarction, heart failure, or stroke. But of course, the impact of quality of life can be profound, particularly in more severe cases where the disease directly impacts social functioning, simple activities of daily living like choice of clothing, and even productivity and absenteeism. So let's look at another illustrative case. This time we have Caleb K., a 14-year-old boy. He is having a current atopic dermatitis flare. He was first diagnosed with atopic eczema at about 4 months. And in infancy, his symptoms were really severe and difficult to control. But these flares mostly subsided after age 5, but he continued with basic skincare. He had infrequent flares since then that tended to resolve with low-potency topical corticosteroids. He has no known allergies except to cats and no pets in the home. So his current flare did not respond to his usual low-potency topical steroids. His pediatrician therefore added pimecrolimus, then switched to hydrocortisone 2.5% with very little improvement. So he was referred to dermatology or allergy for specialty care. And he noted being unable to sleep or concentrate at school because of the itch. And his physical exam showed eczema on his hands and flexural areas of the arms and legs. So what is your next step for Caleb? And this is another poll question. The answer options here are A, start high-dose oral corticosteroids. B, switch to tacrolimus. C, recommend phototherapy, or D, assess atopic dermatitis severity. So we'll give you a minute to cast your vote. You might be having some trouble there. So in this case, the answer is to assess his disease severity so that it can help guide treatment. And there are several tools for assessing atopic dermatitis disease severity. But in general, we tend to use the POEM or the patient-oriented eczema measure in the clinical setting, largely because it only takes a couple of minutes to complete, and it provides insight into the most bothersome aspects of the eczema, such as sleep disturbance, to help focus the clinic visit. In clinical trials, often you'll see the other scores listed above here, like the Investigator Global Assessment or the EASY Eczema Area and Severity Index score. So then, as part of determining severity of atopic dermatitis, which of the following common comorbidities does the POEM assess? Extracutaneous infections, keloid scarring, sleep disturbance, depression and anxiety, or not sure?
So Dr. Senna, I'll give you what we have for the answers here. We have 22% for extracutaneous infections, 6% for keloid scarring, 50% sleep disturbance, 0% for depression, anxiety, and 22% I'm not sure.
Thank you. Sorry, that's not coming up for me for some reason, so I apologize. So the answer here is sleep disturbance. So let's take a look at how at the POEM instrument. So the POEM asks 7 questions, and each question can have a maximum of 4 points depending on the patient's answer. Therefore, the maximum overall score is 28. The score can be quickly calculated in the office, and the patient's score can be used to get a quick assessment of atopic dermatitis severity. The EASY and IGA, like I mentioned before, are used more in clinical trials, but for clinical management, there seems to be this movement towards using the POEM and patient report. But those of us who see these patients in practice may do things a little bit differently, and there's no very clear consensus one way or the other. So if we look at how our patient Caleb completed this, we see his POEM score is a 16, putting him at the higher end of moderate eczema. Which brings us to our next question. Based on this assessment, which of the following would be the next best treatment choice for Caleb? And the answer options here are crisaborole ointment, dupilumab, triamcinolone ointment, methotrexate, or either A or C. Great, so in this case it came up. So 16% of you voted for dupilumab, 11% triamcinolone ointment, 5% methotrexate, and 68% of you A or C. Excellent. So the correct answer is A or C, and we'll review why that is now. So this 2018 publication lays out stepwise management for patients with atopic dermatitis based on the patient's severity. It also provides treatment approaches in both the acute and maintenance phases of the condition. So here, with our patient Caleb, who's in the moderate category, we see for acute treatment that application of a moderate to high potency topical corticosteroid for 3 to 7 days, followed by either maintenance topical corticosteroid, topical calcineurin inhibitor, or crisaborole ointment would be what would be recommended. So what then is the cellular target for crisaborole in reducing the inflammation associated with atopic dermatitis? So the answer options here are calcineurin, Janus kinase, nuclear factor, kappa beta, phosphodiesterase 4, or I'm not sure. Okay, so the answer here is phosphodiesterase 4 or PDE4, and we'll get to what that's all about in a minute. This slide first depicts the mechanism of action of topical corticosteroids and topical calcineurin inhibitors. Topical corticosteroids help to prevent dendritic cell activation, shown here by these Langerhans cells, of T cells, while topical calcineurin inhibitors largely prevent the production of pro-inflammatory cytokines by blocking calcineurin-dependent T cell activation. Topical calcineurin inhibitors are available as cream or ointment and are considered second-line therapy if a patient has an inadequate response to topical corticosteroids. They can be particularly helpful in areas of thinner skin, such as the face, especially the eyelids, as they are non-steroidal, so there are no concerns about skin atrophy or glaucoma or cataract formation with prolonged use. There is a main adverse event that can happen in a small percentage of patients where there can be transient burning or stinging at the site of application that usually is mild to moderate in nature and tends to dissipate relatively quickly. There's a very small subset of patients who have trouble tolerating these medications, though. So as we learned earlier, crisaborole is a PDE4 or phosphodiesterase 4 inhibitor, and it is also non-steroidal. Phosphodiesterase 4 regulates inflammation and is overactive in atopic dermatitis. There were 2 vehicle-controlled double-blind studies, including a total of approximately 1,400 patients aged 2 or older, and these patients had mild to moderate atopic dermatitis and applied crisaborole or placebo twice a day for 28 days. Crisaborole is now, since 2016, FDA approved for patients with mild to moderate atopic dermatitis who are over the age of 2 or older. So the primary endpoint in that study that I mentioned was an investigator static global assessment, or ISGA, of clear or almost clear with at least a 2-grade improvement from baseline. Here we see that 32.8% and 31% of crisaborole treated patients achieved this versus 25% and 18% of placebo patients. Looking at the percentage of patients experiencing clear or almost clear skin, we see a greater percentage of the crisaborole patients achieving this, with 51.7 and 48.5 versus 40.6 and 29.7 respectively. Crisaborole treated patients achieved success in ISGA score and improvement in pruritus earlier than those treated with vehicle. Both of these were statistically significant and also had significant improvement of erythema, exudation, excoriation, induration, and lichenification. The treatment-related adverse events were infrequent and mild to moderate in severity. The majority of treatment-related AEs were application site pain, primarily reported as burning or stinging. Of the patients with application site pain, 76.7 reported it on the first day of treatment, and 77.6 had resolution within 1 day of onset. The rates of study discontinuation because of adverse effects were the same in the crisaborole and the vehicle treatment groups. They were both about 1.2%. So going back to our case of Caleb K, triamcinolone treatment was unsuccessful, as was a trial of tacrolimus. He started treatment with crisaborole, a thin layer applied twice daily, and returns for follow-up 3 weeks later. His rash is worse. He admits to skipping crisaborole treatments because his rash had gotten worse and it was stinging him so bad. And now he completes the poem and his score has gone up so that he's meeting a score for associated with severe eczema. So what at this point is the best next step for Caleb? The options here are no change, reassure him that the sting from crisaborole will go away with continued use. 2, add hydrocortisone 2.5 ointment. 3, discontinue crisaborole, start hydrocortisone 2.5 ointment, or discuss starting dupilumab.
Okay, so we have 6% for the first option, 24% for the second, 6% for the third, and then the winner is discuss starting dupilumab with 65%.
We got a smart bunch here tonight. So the correct answer is discuss starting dupilumab, so great job. And so this is getting to the last section of the talk, discussing the emerging targeted treatment options in atopic dermatitis. So there are new treatments for atopic dermatitis that are based on our better understanding of its pathogenesis, and this has led to development of targeted treatments. Dupilumab is the most recent FDA approval. It's approved in adults ages 18 years and older, and that was in March 2017. Now adolescents 12 to 17 years, and that was approved just a year ago in March 2019. So dupilumab is a fully human monoclonal IgG4 antibody and inhibits IL-4 and IL-13 signal transduction by competitively binding to the shared alpha subunit shown here of the IL-4 receptor. This blocks downstream signaling of IL-4 and 13, altering the atopic dermatitis transcriptome in a dose-dependent fashion. Differences in gene expression following administration of dupilumab include downregulation of markers of epidermal proliferation, downregulation of inflammatory mediators, upregulation of structural proteins, upregulation of lipid metabolism proteins, and upregulation of epidermal barrier proteins, resulting in the normalization of skin. So the clinical trials done in dupilumab, there were 3 primary ones. There were 2 sister 16-week phase 3 trials called SOLO-1 and SOLO-2. And across both of these programs, 1,379 adult patients with moderate to severe atopic dermatitis were randomized to receive placebo or dupilumab 600 milligrams loading dose, followed by 300 milligrams once weekly in SOLO-1 or once every 2 weeks in SOLO-2. One primary endpoint, an investigator's global assessment or IGA score of 0 or 1 with a 2-point or greater improvement, was reached by 37% in the weekly cohort and 38% in the biweekly cohort of patients in SOLO-1. The results in SOLO-2 were similar, with 36% in each treatment group achieving an IGA response. In contrast, you'll see that 10% of the placebo-treated patients in SOLO-1 and 8% of those in SOLO-2 sustained an IGA response at week 16. An additional phase 3 trial called CHRONOS evaluated dupilumab treatment and a concomitant topical corticosteroid compared with placebo and a concomitant topical corticosteroid, and this was done over 52 weeks. Similar results were seen to the SOLO studies, with 39% in each treatment group achieving an IGA response versus only 12% of placebo. And in this slide, we see the percentage of subjects in these 3 studies who had a greater or equal to 4-point improvement in peak pruritus scores from baseline. In SOLO-1 and 2, we see that between 36 and 41% of patients on dupilumab achieved this versus 10 to 12% of placebo-treated subjects. In CHRONOS, the proportion of patients with baseline peak pruritus scores greater than or equal to 4 who experienced an improvement of 4 points or more at week 16 was significantly greater among those treated with weekly and biweekly dupilumab, 51 and 59% here respectively, than among those receiving placebo, 20%. Importantly, this improvement in itch was maintained through week 52 And not surprisingly, there was a parallel improvement in health-related quality of life. This recently published study in JAMA Dermatology assessed the efficacy and safety of dupilumab monotherapy in adolescents with moderate to severe inadequately controlled atopic dermatitis. This was a randomized, double-blind phase 3 clinical trial, and it was conducted at 45 US and Canadian centers. And there were 251 adolescents in the studies. The patients were randomized 1:1:1 to 16-week treatment with dupilumab, 200 milligrams if their baseline weight was less than 60 kilograms, or dupilumab 300 milligrams if their baseline weight was 60 kilograms or more every 2 weeks. Also dupilumab 300 milligrams every 4 weeks or placebo. The dupilumab group achieved both co-primary endpoints at week 16. The proportion of patients with EASI-75 improvement from baseline increased. 41.5% in the every 2-week dosing, 38.1% in the every 4-week dosing versus only 8.2% in the placebo group. In addition, the proportions of patients reaching IGA 0 or 1 at week 16 was also significantly higher, with 24.4% in every 2 weeks, 17.9% in every 4-week dosing group versus 2.4% of placebo. In the phase 3 trials, in the 3 phase 3 trials of dupilumab, so that's SOLO 1, SOLO 2, and Chronos, the overall incidence of adverse events was comparable between dupilumab and placebo groups. But in the 52-week Chronos trial, the proportion of patients with at least one adverse event was greater than that in the SOLO trials. The serious adverse events, importantly, in the phase 3 program were more frequently reported in the placebo group than in the dupilumab group. And the most common adverse events in all trials were nasopharyngitis, upper respiratory tract infection, injection site reactions, skin infections, and conjunctivitis. In all 3 studies, higher rates of conjunctivitis were observed in the dupilumab treated groups than in those treated with placebo, occurring in 2% or less of patients on dupilumab in each trial. Interestingly, there was no significant difference in conjunctivitis rates with regard to once weekly dosing or every 2-week dosing. Interestingly, too, there is no reported increased incidence of conjunctivitis in trials with dupilumab for asthma and nasal polyposis, suggesting that perhaps conjunctivitis is a risk related to underlying atopic dermatitis pathogenesis and not specifically to dupilumab itself. But this certainly can present a therapeutic challenge in a percentage of patients. Injection site reactions were more commonly reported in the treatment groups in all phase 3 trials, and these were generally mild to moderate. Consistent across all trials, skin infections and exacerbations of atopic dermatitis were more common in the subjects receiving placebo. And the incidence of AD exacerbation was similarly higher in the placebo group, with rates more than double those in the dupilumab groups. So here we see the dupilumab dosing for adults versus adolescents. So for those 18 years of age or older, the recommended dose is 600 milligrams as a loading dose, basically 2 300 milligram injections, then 300 milligrams every other week. For the adolescents, ages 12 through 17 years, this is based upon the body weight. So if they're less than 60 kilograms, the initial dose would be 400 or 200 milligram injections, with subsequent doses being 200 milligrams. And if greater than or equal to 60 kilograms, then they follow similar to the adult dosing. So when Caleb is seen back in clinic in 4 weeks, he's doing much better with a POEM score now of 3, putting him in the mild eczema category. He's feeling less anxious and depressed. He stopped skipping class. He's sleeping much better. All good things. And we frequently do see this in our patients who are doing well or better on treatment. So there are a variety of approaches for targeting atopic dermatitis that are emerging now, and they can be anti-inflammatory agents, anti-itch therapies, barrier repair therapies, medications for AD-related diseases like asthma or eosinophilic esophagitis. And we now appreciate that there's this complex dance between immune and epithelial defects, with immune dysregulation leading to skin inflammation and barrier disruption, and barrier defects promoting allergen penetration and Th2 sensitization. So as this slide shows, and sorry if it's a little bit busy, but there are a number of potential atopic dermatitis targets now. Recent research suggests that Th2 inflammation may be initiated by epithelial production of tissue alarmins, such as thymic stromal lymphopoietin, or TSLP. These are likely made in response to infection, tissue injury, or allergen exposure. And these cytokines can lead to a release of Th2 cytokines and perpetuates Th2 differentiation in a positive feedback loop, leading to further inflammation. IL-4 and IL-13 signal through a shared receptor, as we mentioned, and initiate the Janus kinase or JAK1/3 signal transducer inactivator of transcription, or STAT6, what a mouthful that is, signaling cascade, and this leads to the upregulation of the transcription factor GATA3, which is a master regulator of Th2 immune responses. So you'll see that at every point, sort of within that pathway, is an opportunity for targeted therapy. We know that IL-4 and IL-13 promote inflammation by enhancing expression of endothelial adhesion molecules that promote tissue migration of eosinophils, T and B lymphocytes, and also act on B cells to promote growth and induce isotype class switching to IgE, which is where the anti-IgE therapies can be useful. And all activated T helper cells, and especially T helper 2 cells, secrete IL-31, which is an inflammatory cytokine and thought to play a role, particularly in itch, and correlates with atopic dermatitis severity. And lastly, CRTH2, or chemo-attracted receptor homologous molecule 2, is expressed on Th2 cells. And this receptor has been associated with activation of pathways associated with allergy and inflammation. For example, its activation can stimulate migration of eosinophils and Th2 cells, as well as degranulation of eosinophils and basophils. So this chart shows some of the emerging targeting treatments for atopic dermatitis. Among the newer targets currently being investigated are various inflammatory cytokines, IL-22, IL-31, or the receptors, JAK inhibitors, and also the transient receptor potential vanilloid type 1 molecule, which is an ion channel implicated in itch. In particular, 2 injectable anti-IL-13 agents, tralokinumab and lebrikizumab, are showing promise in phase 2 or phase 3 clinical trials, as are several oral anti-JAK inhibitor agents. So with that, to come to our summary slide, we've learned that, or have reviewed that atopic dermatitis is common in infants and may persist through life. Adult onset atopic dermatitis can be challenging to diagnose, and that's really where we need to keep our differential diagnosis open and perhaps consider further workup to make sure that we have the right diagnosis. Multiple differential diagnoses should be considered even in infants, children, but particularly adult patients presenting with eczematous dermatitis. And the comorbidities in atopic dermatitis are common and include other atopic diseases, sleep disturbance, neuropsychiatric illness, cardiovascular disease. The basis of atopic dermatitis management includes skin care, trigger avoidance, anti-inflammatory agents when indicated, and severe atopic dermatitis requires systemic treatment. 2 agents targeting components of the atopic dermatitis inflammatory process are FDA approved, and many others are in development. So we appreciate your patience. It's always hard doing these things remotely. We tried our best to bring you this topic. It's also kind of hard as a speaker because I'm not able to sort of gauge people's responses to the talk and whether or not they have questions. At this point, I'll open it up to any questions that might exist and do my best to answer those.
Yeah, and I'll be happy to take, to send any questions your way, Dr. Senna. So folks that are still on, if you have any questions, please feel free to use the Q&A function on your bottom of your Zoom menu there to submit any questions for Dr. Senna. I know we're just about at the top of the hour, so we'll give a couple minutes here for questions. One question has come in, will the slides be available afterwards? So yes, we will make the slides available to you. Either the email will either come from the France Foundation or from AFA New England. So we'll make sure that you can get those. So here's another question, Dr. Senna. Any concerns about long-term effects of treatment for severe AD?
As far as like with dupilumab or those sorts of agents. So dupilumab, because it's very targeted, seems to be incredibly safe for long-term use. You know, we don't have a lot of data on, or any data really, on a lot of the emerging therapies that we talked about, such as the JAK inhibitors. But when we look at them being used in other disease states now, maybe for 5 years or so, like rheumatoid arthritis and things, it seems as though, at least within that time frame, they can be given very safely, as long as there's proper monitoring and things like that. As far as the topicals are concerned, the percutaneous absorption of these medications are really near zero. Of course, that depends upon the body surface area being treated. Certainly, we worry a little bit more about that, particularly with the mid to higher potency steroids in very young children. But I think that with the topicals, what's important is that we're always selecting either a non-steroidal option or the lowest potency that we're able to choose if it's a topical steroid, and making sure that we're taking the time to educate parents on the proper use of the topical steroids, you know, using them more frequently when things are active, tapering off, not pulling off cold turkey to sort of allow a good duration of response from the treatment, and continuing with the basic skincare, moisturizing, and not doing things that over dry the skin to prevent flares as best as they can. And I'll add to that too, obviously, making sure that they're not applying topical steroids too frequently or on the wrong areas that could increase absorption.
Okay, great. So this question comes from a school nurse. So if a student flares up at school, what is something I can use to get them through the day?
Yeah, so that's always really tricky. I mean, it depends on the student and it depends on what the trigger is. So I know in my personal experience, I have patients with eczema who will be, you know, kind of be mild to moderate, but in the spring when they're outside playing in the grass and things like that, because of their seasonal allergies, they'll have horrible flares. So if this is a child who's coming in after, say, being outside at recess or physical ed and is having a flare then that you suspect might be seasonal, what you can do in the office at that point is give like a non-sedating antihistamine, assuming that that's part of, you know, an acceptable thing for the parents, like either Claritin or Children's Allegra or Zyrtec or something like that. And then it's a conversation with the parents, if there is a trigger like that, to see if it would be worthwhile to keep a student like that on a regular antihistamine seasonally or throughout the year, depending on the situation. The other thing is, if you're allowed to have a mid to high potency topical steroid in office, that's something that can sort of provide pretty quick relief to the area. So if that's something that you have and you have a protocol in place for that student where you're allowed to apply for flares, that's something that can start to work in a localized fashion pretty quickly, I'd say within the hour, to provide relief, if not sooner.